Bicuspid aortic valve disease was once considered a near absolute contraindication to transcatheter replacement. That position is no longer defensible at experienced centers in 2026, but the word experienced is doing a lot of work in that sentence, and the nuance behind it matters enormously for patient selection and for honest informed consent. Bicuspid anatomy is not one thing. Type 0. Bicuspid valves without a raphe behave differently than type 1 valves with a raphe, which behave differently than functionally bicuspid valves with asymmetric cusp fusion. The calcification pattern, the elliptical annular geometry, and the aortic root dimensions all independently influence the procedural complexity and the expected outcomes. Lumping every bicuspid patient into the same risk category is the first mistake to avoid. The registry data from experienced centers is genuinely reassuring. Procedural success rates above 95%, 30-day mortality below 2% in low to intermediate risk patients. Paravalvular leak, which was the primary concern driving early caution, has improved dramatically with new generation devices and CT-guided sizing. The data supports offering transcatheter aortic valve replacement to appropriately selected bicuspid patients at appropriate centers. Two findings from the registry data deserve explicit attention at every heart team discussion. Pacemaker implantation rates are higher in bicuspid anatomy compared to tricuspid anatomy, driven by the implantation depth required for stable positioning in an elliptical annulus. An ascending aortic dilation coexists with bicuspid valve disease in a meaningful proportion of patients. An aortic root above 45 millimeters or growing rapidly deserves its own conversation about surgical management, regardless of the valve decision. My framework at the heart team table. Bicuspid transcatheter aortic valve replacement is appropriate at high-volume centers with dedicated CT planning and a cardiac surgeon physically present and prepared for conversion. The patient under 65 with bicuspid AS and a non-dilated root who would accept surgery deserves an honest conversation that surgical aortic valve replacement remains a reasonable and durable first-line option. The older or higher risk patient who declines surgery can now be offered transcatheter aortic valve replacement with real confidence. What has been your institution's experience with bicuspid transcatheter aortic valve replacement outcomes compared to tricuspid anatomy? Has the learning curve affected your results, and how are you approaching patient selection as the evidence base matures? Share your experience below.